I'm Elizabeth Saywick, and as Director of the School of Nursing, I am so pleased to welcome you this evening to our 50th Marion Woodward Lecture. I'd like to begin by acknowledging that we are on the traditional, ancestral, and unceded territories of the Coast Salish people, and specifically the Musqueam, the Squamish, the Stalo, and the Tsleil-Waututh nations. The Mr. and Mrs. P.A. Woodward Foundation has generously supported the annual Marion Woodward Lecture since 1969, 50 years. As many of you know, on October 24th, 1969, the first Marion Woodward Lecture was held, and it was as part of the annual homecoming celebration. Beth McCann, who was the director at the time, actually had approached the foundation, which had been so generous in funding so many other things like the Woodward Library and the Instructional Resources Center at UBC, and so asked for sponsorship for the lecture. Although Marion Woodward had never allowed her name to actually be used in conjunction with any of the philanthropy and those grants, she actually met with Beth McCann and agreed to have the lectureship named in her honor. And in fact, she attended that initial Woodward lecture that was, I think, given by Helen Masalem, and she hosted a tea in her home afterwards. I never had the opportunity to meet Marion Woodward. She precedes me by a number of years, but from what I've seen from the history, she was remembered as someone who was gentle and well-liked. Friends and family members alike talked about her kindness and how thoughtful she was as a person. She regularly sent flowers and sometimes even bed jackets to female staff who ended up in hospital. She was an active, although a bit more of a silent partner in the extensive philanthropy that PA and she were involved in. Now, the foundation's focus, really driven by P.A. Woodward, was on health, and it was influenced to a great degree by losses in his own life. He lost his mother and a few of his siblings to tuberculosis, and when he was only 4 years old. And then about 8 years later, his oldest brother Jack also died of tuberculosis. His own son died of Hodgkin's disease at age 18, and Marion herself suffered from chronic health conditions like diabetes and a number of small strokes over the years, and so she did end up with some mobility issues. So it's not surprising that they chose to really pour their energy and wealth into improving the health of British Columbians. And that was with the establishment of the foundation. The primary focus has always been on health. This is, in fact, BC's largest private charitable health care foundation. The foundation has contributed the resources to building a variety of hospital units and healthcare facilities, but primarily focusing on hospital equipment and a host of other kinds of resources over the years. They founded, of course, this lecture, presenting leading-edge nursing issues to nurses and nurse educators over the years. In 2012, with the guidance of the foundation's president, Mr. Kip Woodward, the definition of health has been expanded to include covering the changing mental health needs of people, growing social issues. They have, for a while, funded some of the more controversial health issues of their times. You know, in the 80s, actually funding research, or not research, but healthcare for people with HIV, funding supports for women in violent relationships, a variety of other work that other foundations have been perhaps slower to actually take up in BC. And tonight, we are delighted to be joined by Mr. Kip Woodward himself, the president, to say a few words as part of this time. You know, he has continued the legacy of his aunt, great aunt actually, right? Mrs. Marion Woodward, in support of this nursing lecture series. Just a brief word about him. He was appointed as president to the foundation in 2012, as I mentioned, but he's also served as chair currently of the Board of Vancouver Coastal Health and was for a number of years the chair of Providence Healthcare. He's the president of Woodcorp Investments Limited, which is a venture capital investment firm, and has represented a number of organizations as chair, including the Brentwood College School, the Nature Trust of British Columbia, the Keg Royalty Trust Fund. He currently serves as director of Village Farms International, the Great Western Brewery Company, and Sea to Sky Gondola Corporation. I'd like to invite Mr. Woodward up to say a few words.
Well, I think I find myself wearing many, many hats in this role, but I'm actually really delighted to be here, and a good evening to everyone who's here tonight. This one evening is our longest continuous grant that we've given in the Woodruff Foundation. I know I was just a small boy when I knew Marion and her husband, PA. I recalled him as being a very gruff man in a three-piece suit, smoking cigars and drinking scotch. Marion was a very genteel woman, often with a nice nightcoat on in a wheelchair, and I could now look back in years and say she was a gentle soul. And Puggy, whose nickname Pugnacious, it was an interesting combination. But for sure, their experience of their lifetime in the early 1900s, early days of British Columbia, I think had a profound impact on both of them. And Puggy, when he passed away finally in the early 1960s, his entire estate went into this one foundation, and it was all to do with the health of British Columbians. It wasn't for research, it wasn't for buildings, but it was for clinical care. It was to promote and support the care that nurses and allied workers and doctors did at the facing of patients. And that's our guiding principle to this day. So we've been very lucky. We've given away over $50 million in British Columbia. I think we started with about $3.5 million in the early 1960s, which was a huge fortune in those days. And we've grown that now to over 45 million. We've given away 55 million. So it's a wonderful math exercise of compounding interest. And so my fellow directors and I, all we try to do is make money and give it all away. That's our purpose. And I know that Marion, for some reason, Puggy had this wonderful relationship with physicians. There was no medical school in the day. I think it came after World War II. Somehow he got teed up. Maybe it was through card games and whiskey drinking with some of the early physicians. But he did build the library. He really supported the first the medical school here. But I do know that Marion would say, "Now, honey, it would be the doctors are all fine, but the people who actually provide the care are the nurses." And so if I take my other hat off, and in my role as chair of Vancouver Coastal, there's nothing more important than that one very function. And I'm thrilled tonight that our foundation, and Elizabeth was telling me that our foundation is to build capacity and excellence. And we're doing this through UBC and through the School of Nursing and through these type of lectures tonight. I'm thrilled to think that maybe this is one of the few places in Canada where we actually have excellence. We can bring in excellence for everyone to learn from, and that we'll always have this, you actually have funding in perpetuity, unless the whole world stops, but you've already told me that next year's your 100th anniversary, so I expect we'll probably get another request for something bigger than what we're doing. And so anyway, have a really good evening, and I can tell you, thank you from all of us in our community for the work that all of you do. And it's really this group here that you set the dial, you set the standards for the care that we provide in all our hospitals and homes. So thank you very much for coming tonight, and thank you for allowing me to speak. So.
Thank you so much, Kip. And yes, we'll be in touch about the centenary. And now I would like to call up our Professor, Associate Director of Research, Dr. John Olaf, to introduce our Marion Woodward lecturer. Thank you.
Okay, so I have no idea what I'm about to say, but I do have a script. I'll read some of it, but just to say, after every Marion Woodward lecture, we invite feedback. And we invited feedback last year, and we had a lot of people coming up with a particular name. And so that helped us think about who the 50th keynote speaker might be. And the name that continued to come up, and special thanks to Tracy and et al., a number of other people, was Dawn Stacey. And when we contacted Dawn, it was very easy to work with her and chat with her. She's got an amazing background, has done amazing things. She's a research chair in knowledge translations to patients, scientific director of the Patient Decision Aids Research Group, and she's a professor at the School of Nursing at the University of Ottawa. But of course, that's just the official bio. When you Google her, it comes up with more than 13,000 citations for her. PubMed reckons that she's got more than 378 publications. And what those numbers suggest is that she's amazing in terms of volume, but also in terms of impact in the field, which is a terrific legacy because she operates at a much higher level as well as the empirical level. She leads organisations around patient decision aids. She's done amazing work. Last night, she had Arctic char for dinner at Shambar. And that's not on Google, ladies and gentlemen. You had to be there. Just saying. The other thing I learned about Dawn just recently is I was up at the bar and I was telling myself, look, John, don't have a drink because you've got to talk. And Dawn was having a drink and I thought, hell, if she can have a drink and do a keynote, why wouldn't I? Clearly I did. Dawn didn't finish hers. It's on the podium. I'm surrounded by smart people, clearly. It is my delight to welcome Dawn Stacey to the stage. Thank you.
Well, thank you very much for the invitation to deliver the Marion Woodward 50th anniversary lecture. I remember when the email came, and I was talking to Elizabeth a bit earlier about how you have to learn how to say no, but that was one that was just like, wow, really? Like, I'd be so honored to be able to be here. And I think the piece that makes it more exciting to me is it's a lecture specifically for nursing. And whenever I get these requests, which is almost never, because it's usually other requests that I get, it was just very clear that I would love to be able to deliver this lecture. And Tracy, I'm not sure, oh, there you are. Thank you so much for putting my name forward and others that did as well. But I'm very happy to be here. And I was also thinking, I actually did my PhD in population health at the University of Ottawa, but I actually did my PhD with the BC Nurse Line. And so during those years, I would fly out to do my data collection and work with the BC Nurse Line, and then fly back home, because I had children in school-age children, so I couldn't be gone for very long. But I have very good feelings about Vancouver, and I also lived on Vancouver Island for a couple of years as a child. So BC is not that far out of my everyday thinking about my life. So I'm very happy to be delivering the presentation, and I've titled it Strategies and Tools for Putting Patients First. And we'll talk to you a little bit about my perspectives around what do we need to be thinking about if we're actually putting patients first. So in terms of disclosures, the School of Nursing, and I'd like to thank the Woodward Foundation for paying for my travel to come and be presenting the lecture tonight. The only financial disclosure is I did have a consulting contract with Washington State Healthcare Authority to help them set up their certification criteria for patient decision aids and then training. And then I also been invited by many organizations in the world around doing lectures and paid for travel. So one of the first things I want to start with is the British Columbia Patient-Centered Care Framework, because when I saw the framework and had a quicker look at it, I was actually very pleased with what are the sort of the key words in this framework around what's patient-centered care. And in this definition, they say they put patients first at the forefront of their health and care. They ensure that they retain control over their own choices. It helps them make informed decisions, supports a partnership between individuals, families, and healthcare service providers. And the key components are around self-management, shared and informed decision-making, an enhanced experience of healthcare, improved information and understanding, and the advancement of prevention and health promotion activities. And this is like word for word. And I highlighted all the words that I think are really essential, but also are going to be relevant to what I'm going to be talking about tonight. So this quote came out of the Patient First Review update from Saskatchewan, and I have been doing work with Saskatchewan over the years, government, around looking at improving patient-centered care. And the real problem is that patients and their family members are often not given the opportunity to make informed choices about best possible healthcare services for their individual needs. And we know this actually repeatedly in studies even today. With good intent, healthcare providers often believe that they know what's best for their patient and make decisions for the patient rather than with the patient. And tonight I'm going to talk more about what does it mean if we're making decisions with the patient. Interestingly, in terms of a little historical note, in 1848, the American Medical Association Code of Ethics advised physicians not to consider patient perspectives in medical care. And so we really need to look at how do we shift to it being included in all things that we do. And this comes back to Al Mully and colleagues published a paper a few years ago in BMJ calling Stop the Silent Misdiagnosis. Patient preferences matter. The correct treatment recommendations require accurate diagnosis, not only of the medical condition, but also about patients' treatment preferences. And so I'm going to talk a little bit around what is that piece around how do we bring patient preferences also into decision making. So just coming back to the BC Patient-Centered Care Framework, the practices that are required if you're meeting this framework around patient-centered care is that you need an organization-wide engagement, leadership support to achieve a true partnership. So again, keywords around leadership and partnership. We need a workplace culture renewal, a model of care where the patient is a partner in making health care decisions. We need balanced patient-provider relationships to overcome the power imbalance, to have patients as true partners in the process of making care decisions. And then the fourth practice that this document talks about is tool development, to assist in putting the needs and voice of patients and families at the center of care. So it's a nice place for me to start when I see this wonderful document from the BC government. So in my presentation this evening, I'm going to talk then around what is patient engagement in health, and I'm going to talk about, as I said in the title, strategies and tools to put patients first. And I'm going to actually talk about it in a broader conceptualization around decision-making and policy, organizational design and governance, research, and direct care. But probably most of my presentation will focus more on direct care, which is where most of my research sits. So the framework that I like, that when thinking about patient engagement, is the Karman Framework, and I did adapt this framework. I think I have a pointer. And I added in research as a specific element in the framework. Because I think, especially in Canada, there's a big push that we also include patients as part of our research teams. And so I'm going to be using this framework as I go through. And in this framework, they talk about levels of engagement. So consultation is the lowest level. involvement higher, and then partnership and shared leadership, and at the 4 different levels. And I'm going to come and speak to each one of these individually. But before I do that, I'd like to just talk about what does it mean in terms of these levels of involvement. So at the lower levels of involvement, it's really around we as the expert here with a big ball are helping inform others and educate others. So it's a very one-way direction around we're telling others what they need to know. So this is like patient education is sometimes fit into this. Gathering information, so we sometimes go out and collect data from patients when they're discharged from hospital and say, how was your experience? And we collect that data. But again, it's coming in to us in control of how this information is collected. We might discuss, so there might be patient advisory committees where we discuss things. We might engage where there's a discussion across, but if we're actually at a partnership and shared leadership level, the big difference is these balls are all the same size. And so each one of us at that table is equal in their contributions, and there isn't one person sort of that's more important at the table. All voices are equal. And so this is really what we're aiming for if we're looking at the highest level of partnership and involvement. So coming back to the Karman Framework, at the level of policy making, if we're just consulting, we're using public agencies, conducts focus groups, or ask questions. Involvement is patient research priorities are used for making funding decisions. And at the highest level of partnership and shared leadership is when patients participate in decisions about how to allocate resources in the province. So in Ontario, for example, I've met one of the patients that actually sits on the Ontario Drug Benefit Plan and makes decisions on how to allocate resources. And she says it's quite amazing. She has a rare disorder, and she said for her, she wants all rare disorders to have all drugs approved, but she also has to sit there and decide this small pocket of money, how do we fairly distribute it around all those drugs that we need to be thinking about for all those conditions. So that's an example of patient engagement at that highest level of shared leadership. So why is it that we should be engaging in setting research priorities, which is sort of at that middle called involvement? Because there's a real mismatch between patient priorities and the priorities within research portfolios. And this example was cancer in the UK. And so we've had this shift, and there was examples earlier this afternoon around how patients are involved in also setting research priorities here in the province. So one of the strategies that's a strategy to consider in terms of involving patients is the Lin Alliance. And they establish setting up the top 10 priorities around uncertainties and unanswered research questions, but around what matters most to both patients and clinicians. And so both sit at the table when they're setting these research priorities. So I was involved in a process of setting research priorities for cancer or kidney research in Canada. And what was interesting in the top 10 list in the end is that supportive care needs and interventions for patients and families and decision-making tools for patients and healthcare professionals were within the top 10. Next to biomarkers, immunotherapies, so many different types of more medically driven priorities for research, but within the top 10 is 2 that were clearly driven by the patient group at the table. So the next level of patient involvement is in organizational design and governance. And at this level, just go back. At consultation level, we do organizational surveys about their experience. And so many hospitals follow up post-discharge and collect this information. Some hospitals have patient advisory committees where they're established, and I would say probably many hospitals have this level. But if we're actually to have shared leadership and partnership, the patients would co-lead safety and quality improvement committees. So interestingly, I was in Melbourne at the Alfred Hospital, and they actually have moved forward to having patients co-leading the patient safety committee, but there was a lot of concern on whether or not they really wanted the patient to know the real data, the real stats, the real patient injuries and the unsafe situation. But the reality is that patients are co-leading these committees in some of the hospitals. So what do we know? There was a recent review published this year on organizational outcomes when patients become involved in organizational design and governance. And what this review reported is that there's enhanced quality of care, enhanced care, there's a They've developed specific policy or planning documents. They've created educational tools, enhanced governance. At the institutional level, there's more engagement. There's actually been a cultural shift or a cultural change that has a higher value for the patient voice. There's a neutralization of power and a mutual learning that goes both ways. And at the patient level, patients are more satisfied when they're involved, educated, they have increased self-esteem, they feel more empowered, and they also develop skills as being part of these teams. But the challenges are patients' energy and time, because these things take time to be on these committees. But the biggest one is they felt tokenistic when the request denies decision or the decision is already made. So we really have to be careful around whether or not the patient is a true partner and there is shared leadership, or whether or not we're ticking the box to say there's a patient on this committee, but we're making all the decisions before it gets to that committee. So the next area is around research. And so at the consultation level, we often conduct focus groups and with patients to ask their opinions and get their picture of the story. At the involvement level, we might have patients suggest what the research questions are, but if we're actually reaching shared leadership and governance, the patient would be a co-partner on the team. And so there is a bigger shift right now to looking at how can we have patients as part of the team. And this afternoon, there was actually quite a number of projects discussed where patients were part of that team. So CIHR, within their patient engagement framework, they talk about patients meaningfully and actively collaborating in governance, priority setting, and the conduct of research. They also talk about them being involved in summarizing, distributing, sharing, and applying the results of the knowledge after the study is completed. And I also been involved in research studies with PCORI in the US, which is the Patient-Oriented Outcomes Research Institute. And the reason why they want us to do more research with patients on our teams is it's more likely to be patient-centered, useful, and lead to greater use and uptake of the research results when we're done. So Dominic and colleagues out of Montreal, actually, they did a review of, and they identified 142 studies around whether or not patients could be involved on research teams. And the bottom line was yes, it was feasible in most settings. The most commonly done is at the beginning of research around setting the agenda or protocol development. It's less common during the execution or the translation of the research. And the benefits to the patients and the team is that it aids researchers in securing funding, designing the protocols, and choosing relevant outcomes. And there's increased study enrollment. There's actually, I was just reading a paper that's coming out soon, but in this study, they actually talked about the patients changed the enrollment and the criteria and the inclusion, and that it sometimes interferes a bit with the research methods piece, but it's just more realistic in the end, and it's more likely to be successful. But the challenges the patients discuss is the logistics, the time and funding needed, and the overarching worry, again, of tokenistic involvement. So we say there's patients on the team, we submit the grant to CIHR, we get it funded, but then that's it. We haven't really engaged them as part of the research team. So I actually work with patients on my research teams, but one of the other things is anybody that does their PhD with me for sure, and sometimes with masters, is we often get patients involved in those projects as well, so that it's part of how you learn about doing research as opposed to later trying to figure out how to do this. So I was involved with Holly Whitman at the University of Laval in Quebec City on a PCORI grant, and we had a huge team. I think there was like 25 of us, and of the team, at least 5 were patients on our team. And we actually just published a paper on our 12 lessons learned for effective research partnerships. And in this slide, we have what's important for all research teams and what's important for partnered teams with patients. So what we found is that it's really important to have a full person team meeting as early as possible so that we actually get to meet the people and develop a relationship and develop the trust between the researchers and the patients or the knowledge users on the team. The next was to introduce yourself with a story and not a title. Traditionally, we often are given or use our titles as who we are as a person, but when it comes to having these conversations with patients, we should be telling the story around why I'm sitting at the table, not just because I'm a professor sitting at the table. Another one, I've highlighted in red sort of the key, but my dots on the other end haven't lined up. But offer some kind of orientation. So there is more around training of patients on how to be on teams, but there also is a need to train the researchers on how to work with patients on teams. And in fact, mutual training is better, or training together is better than sort of separate training. So thinking about preparing everyone for their role on the team. Ensuring enough funding for everyone's participation. Luckily, this was a PCORI grant in the US, and it's very normal that everybody gets funded to be on that team. Even I got some funding for being on that team. And think carefully about labels, jargon, acronyms, that this really interferes with that flow of conversation. And as one of the patients that spoke this afternoon kept saying is, when she was involved, she kept putting her hand up. What does that mean? You have to explain this. And also Mario talked about not using too much jargon or acronyms because it's much harder for them to follow. And then the other one that we found in our group is we sometimes use smaller and more homogeneous groups as breakouts from the big group, and then we came back so that everybody had a chance to talk, and not just those that were more vocal. So if you want to know more about what we call integrated knowledge translation in Canada, that there is a research network that I'm part of. It's led by Ian Graham in Ottawa, and there's a website, and they actually have started collecting videos and different documents around involvement of knowledge users. So knowledge users could be policymakers, patients, healthcare professionals, and there's a number of resources being pulled together on this website. So the other area around patient engagement, which is probably the one I'm most passionate about, is really around direct care. And so at the direct care level, patients receive information about their diagnosis. It's more passive. Patients are asked their preference. But if we're actually to reach a partnership and shared leadership, the decisions are made based on patient preferences, evidence, and clinical judgment. And that we're really working together around how do we make decisions at this level. So this is really the definition of shared decision-making. Shared decision-making is a process by which decisions are made between the patient. When I use the word patient, I'm also referring to the family at the same time, and the clinician using the best available evidence and patient's-informed preferences. And the three key elements necessary for shared decision-making at a minimum is one, that people need to be clear that a decision needs to be made. So 50% of the time, the patients will say, I never even knew a decision was being made. They were just sent off to surgery or whatever. They were not actually informed that there were alternative options that they could be considering for managing that condition. The next is information exchange, and I like this is from our interprofessional model of shared decision-making framework, we talk about exchange because it's really a two-way. Patients and the public come with lots of their own views on what their options should be, and so the information should be in exchange. What do you understand about your options? And then what are my perspective as a healthcare professional around what the options are in the situation? Around information exchange, we talk about what are the options and what are the benefits and the harms of the options. And so also oftentimes when people find out about an option, they only hear about the benefits of the option. There's much less discussed around what are the harms, the risks, the side effects, the consequences of some of these options. And then the third really important category is around the values and preferences of the patient. But at the same time, I as a nurse need to recognize what are my values and preferences that are going to be influencing my interaction in this situation. And I need to put them aside and try and listen to the patient's perspective around what's really important to them and what's the best fit in their own personal circumstances and what they're talking about as being important. And Weston's described this as really being the crux of patient-centered care if we're providing shared decision-making. But we know it's not happening in practice very well. So this is a review that was done by Natalie Joseph Williams where she identified 44 studies that identified the patient's perspective on the barriers and facilitators to shared decision-making. And what she found and reported in the study is their individual capacity to participate depends on these two sort of big areas that we need to be thinking about. The patient said they need to have the knowledge about the disease, options, and the outcomes. And they also have to have knowledge about their personal values and preferences. They need to have someone talk to them about them and get them to think about what's important to you. But at the same time, we need to be dealing with the power imbalance. They've described they need to have the perceived influence on decision-making encounter really depends on whether or not they're given permission to participate. They feel confident in their knowledge, and they feel self-efficacious in using their skills in being involved in decision-making. And so very often in healthcare systems, we have huge amounts of patient information, patient education materials that we give out to patients. But nobody sits and talks to the patient to talk about what's really important to you in this situation and what will work best for in your own circumstances. So France Legaré in Laval University, she leads this Cochrane review on interventions for increasing use of shared decision-making by healthcare professionals, and Jen Krivoruchko is actually a co-author and has been since the original. And in this Cochrane review, what we found is that the healthcare professional, shared decision-making can be learned, and we need to target both the healthcare professionals and the patients. And the bottom line is healthcare professionals generally need training on how to involve patients in decision-making, and we know that this isn't done well in any medical schools, probably. And we also know that we need to have patient-mediated interventions, such as patient decision aids, that help to support the patient to be able to be involved in these decisions. So I'm going to talk about a few tools that can be used to help facilitate patient involvement in decision-making. And I'm going to start with Bedside Handover, but also we'll talk about decision aids, decision coaching, and then question prompts. So this was another review paper about bedside handover, and the bottom line is few patients and families are involved in bedside handover, and hopefully we're getting better at this in terms of how patients and families are involved. But in this review, there were only 3 studies out of 45 that talked about patients' involvement. In one study, it was only 5% that were very superficially involved by just a greeting at the bedside. In another study with maternity patients, about half were involved, and in another study, it was less than 50%. But there's definitely room for improvement in patient involvement. And the benefits to the patient that was reported in 8 of these studies is that they can obtain information, they can also verify what's being said, they feel reassured when they're able to participate in shared decision-making, and so this is actually an opportunity when we can actually involve the patients in decisions that are being made. And there's also increased satisfaction when patients are involved in bedside handover. But the negative effects on the patients that was identified in 3 of the studies was the clinicians use jargon, so they get frustrated. And it also can be very patronizing or tokenistic. And we need to really look at how do we clarify the role of patients in handover, because we also don't want to be there all day doing handover. We need to be able to figure out efficient methods. And then we also need to be able to ensure that they are involved. So I remember when my grandmother was in the hospital with a bowel obstruction. She was 88 years old, and she was on a surgical unit, and I would go sit with her all day because she was so unwell and never see anybody that could tell me what was going on. And so I put on my hospital ID because I'm a senior scientist at the hospital, and I went in at 5 in the morning because if I wanted to see the surgical team and find out what was going on, I had to be there sometime around 5:30 to 6:30 in the morning. And they showed up, and they were quite incensed with me being at her bedside because they didn't involve her in anything. They would talk among themselves over her, and they were incensed that I would sit there, and I actually asked them questions, and they were like not prepared for me to be involved in this bedside rounding that they were doing before they went into the OR. But I think there was, at least sitting there, I could hear what was they were discussing, and as a nurse I could follow, but they never really involved my grandmother in any of this. So I think we as nurses can be doing this in our handovers, and then as teams also need to be thinking about this. So in terms of patient decision aids, a patient decision aid is considered an adjunct to counseling. It's not to replace the interaction between patient and healthcare professionals. They provide information on facts, so the condition, options, benefits, harms. Some decision aids also communicate probabilities or what's the chances of a benefit or harm occurring. Decision aids help them clarify their values for outcomes of options by asking them what is most important to you or what matters most. Some decision aids share patient experiences or stories or narratives in a way that helps people think about whether or not they're like this person or that person, and it also is a way of helping them clarify what's important. And then decision aids often guide in steps of deliberating, communicating. Some have worksheets or interactive, and some have lists of questions. The format for decision aids, some are used prior to going into the consultation, and others can be used within the consultation. They can be printed materials, DVDs or videos, or online or computer-based types of materials. And so I lead the Cochrane review of patient decision aids, and what we know from over 100 trials of decision aids is that they have patients exposed to decision aid have higher knowledge, more accurate risk perception, and a better match between what their values are and the choice that's made. There's less decisional conflict. It helps the undecided decide. It supports patients to be less passive in decisions. And so this is my interactive part. So if you were to enter the healthcare system tomorrow for yourself or a family member, would you want to be active in how a decision gets made about your health or the health of the family member? So how many people would say yes? So I'd say probably almost 100% of people in the room. And what we know from surveys of the population or the public, it's over 90% want to be involved. Those that don't want to be involved are the older adult. Like my grandmother would say, no, that's not my job. But as soon as I get her in the car to drive her home from the cardiologist, she goes, well, I'm not doing that. And I'm like, this isn't the time to be discussing that. But so we know that some people think that they don't want to be involved, but I remember I was at the cardiologist, she was an atrial fib, and he's like, oh, we're going to go and defibrillate or whatever. And I'm not a cardiac nurse, I'm an oncology nurse. And I just looked at him, I said, do you really have to do that? She really doesn't like it when you do that. And he's like, oh no, she's on medication, it covers her. So no, you're right, we don't have to do that. But if I hadn't have spoken up, they would have moved forward and not asked her what her preferences are. So what we know, though, in terms of people being involved, I'm an oncology nurse, and as soon as you deliver a diagnosis of cancer, the patients go, oh, you're the expert, tell me what I should do. And I do work in prostate cancer. And we know really clearly that if they see the surgeon will recommend surgery. If they see the radiation oncologist, he'll recommend radiation. And we also, there's 2 published papers, one in the US and one in Canada, that says that those same surgeons and radiation oncologists won't even necessarily have what they recommend to their patients if they themselves got diagnosed with prostate cancer. And so what we need to know is that the patients, we need to look at how do we support the patients to be able to be involved in these decisions. We know that with patient decision aids that they're more likely to be involved because we help give them the resources and tools they need to participate. There's improved patient-practitioner communication when patient decision aids are used. These are when used in the consultation. I talked about 2 different types. Anybody that measured this as an outcome only measured it when the decision aid was used in the consultation. And then we do know that decision aids can reduce overuse or underuse of some options. And so we know with elective surgery, we actually decrease elective surgery when patients learn that there's other options beyond surgery. We also know that they've decreased prostate-specific antigen testing to screen for prostate cancer when men found out what are the benefits and harms of PSA testing. And in fact, now it's in most of the guidelines. I think Canada recommends against it, although there was quite a bit of debate on the committee when they came out with that recommendation. The US actually recommends shared decision-making, that in every situation it should be discussed as opposed to just a recommendation for or against. And also in our latest review, we found there was actually an increase in new diabetes medications prescribed when patients learned about different options for managing diabetes. So that's one where there was actually an increased uptake. So the next thing people say to me is, oh, but these won't work with my patient population because they're more marginalized and they have low socioeconomic status. But in this review of 19 studies, what they found is there's actually even higher outcomes, more significant outcomes for disadvantaged patients. And it might even be more beneficial that we use patient decision aids with them than with those with higher literacy or higher socioeconomic status. And the reason is because oftentimes people with higher socioeconomic status, they have their own networks and their own ability to understand what's put on the internet, or there's different ways of getting information. And so we shouldn't shy away from looking at using these types of tools with people with all different types of people. So in around 2003, we started to be really concerned because the first systematic review on patient decision aids was published in BMJ in 1999. And then we were concerned that, they can affect uptake of options. And so this uptake of options is good when a decision aid is unbiased and when the change addresses variations because of poor understanding or there's a preference misdiagnosis. But we were concerned if the uptake is due to biased information. And there were a lack of standards at that time for looking at quality of decision aids. And I remember I went to the second year nursing class, and it was obstetrics and gynecology, and we sent them off to find a decision aid on bottle versus breastfeeding. And they went off looking, and they found one by the infant formula company. And so anyway, we had to have a big discussion around it. And I knew HealthWise, which actually is used by the BC Health line, or Nurse Line, and also it's available resource. They had one. But interestingly, they pulled it because the physician on the team at that time, because I contacted them, said this isn't a decision that women should be involved in. They should all be breastfeeding. And I said, no, why don't you show them the evidence? Show them the benefits and the harms. Why are we being patronizing about every decision? We should let them see the evidence and see. So anyway, it's back up there in their list of decision aids. But we know that there are a lot of decision aids being developed in a biased way. So we have to look at standards for looking at quality. So we established in 2003 the International Patient Decision Aid Standards to enhance quality and effectiveness of patient decision aids by establishing a shared evidence-informed framework for looking at what's their content, how they're developed, how they're implemented, and how they're evaluated. And I'm co-leading it right now with Bob Volk from the US, and we have representation on our team from many different countries in terms of leading the standards. So if you want to find a patient decision aid, you just Google decision aid, and you'll come to, we in Ottawa have the International Inventory of Patient Decision Aids, and Ed O'Connor created this alongside the Cochrane Review. And if you type in osteoarthritis, which I've done here, you can actually then come to information on that decision aid. And this is one, and click here to actually view the decision aid. This is a HealthWise one, and it's also, I have the access to the US version on this in our inventory, but you have direct access to the Canadian version. And we also rate all the decision aids against the international standards. So you can see here it meets the criteria for being a decision aid, and it meets 8 out of 9 criteria for lowering the risk of making a biased decision. These criteria were then adopted by Washington State Healthcare Authority, and they set up the first certification program in the world to certify patient decision aids in 2016. And in here you can see examples of the criteria that are part of the definition of a decision aid, and then it goes on to criteria for minimizing risk of bias. So the next intervention that you can be thinking about, I should probably just look at the time, is decision coaching. And so decision coaching is when a trained healthcare professional who's non-directive and provides support that aims at developing the patient's skills in thinking about the options, preparing for discussing the decision in a clinician consultation, and then implementing the chosen option. It can be delivered face-to-face or using the telephone. And so my PhD work with the BC Nurse Line was looking at what's their role in providing decision coaching and using patient decision aids. In the review that I already talked about from the patient perspective, their solution to overcoming barriers and facilitators was that they wanted to enhance workflow. They wanted the nurses to explain the information, provide support by listening to patient preferences, and provide doctors with the patient preferences. And so they never actually thought they could overcome that power imbalance. They thought they needed a mediator in terms of doing this. And so in my work with decision coaching, I do a lot of work with nurses. I do work with psychologists do work with social workers. There's a number of people that can do decision coaching. Family doctors actually are excellent when it's a surgical decision that needs to be made with the surgeon. And so it's a way of helping the patient think through the decision. In terms of the evidence around this, we did a review looking at decision coaching used alongside patient decision aids. And what we found is that the knowledge improved compared to usual care. The improvement in knowledge was similar to those that got a decision aid. And the improvement or no difference in other outcomes. And so it's not harmful in terms of doing decision coaching. And so we actually created a generic decision aid that can be used for any health or social decision. And you can get this off of our website, or you can Google generic decision aid. And we actually have the original one that's available in multiple languages, and we also have one for two people, where it's a couple making a decision about a child, or a parent and a child, or it could be for a grandparent as well. And this is what the Ottawa Personal Decision Guide looks like, and you can see here you write down what are the options, what are the reasons or benefits or advantages, how important is this to you? It's rated on a 0 to 5 for each of the benefits. What are the risks or the harms or the disadvantages? And then how important are they? So the last one that I wanted to talk about and wrap up is around question prompts. So the group in Australia, led by Heather Shepherd, they created 3 questions, and it's called the Ask Intervention. And it's, what are my options? What are the possible benefits and harms of those options? And how likely are those benefits and harms to occur? And what they found when they did this with simulated patients is that it improved information that family doctors gave, and it increased the physician facilitation of the patient's involvement in decision making. This group then went on to try it in real life time in primary care, and they showed in the waiting room a 4-minute video on how to use the questions, and 78% of the patients saw that video. And what they found when patients were prepared is that 69% asked one question or more, and 29% asked all 3. But if they were actually making a decision, 87% asked one and 43% asked all 3 questions. And so this is a very simple intervention that can be used to help stimulate discussion around alternative options. So in the UK, as part of a public campaign to let people know they can be involved in health decisions, they actually distributed this flyer called Ask 3 Questions, and they changed the 3rd question. It says, how do I get support to help me make a decision that's right for me? And so they used the first 2 questions, but they did a public campaign. They posted this all over and said, you have a right to ask these 3 questions. So coming back to the framework, the reason why I do a lot of work at the direct care level, but my thoughts are that if we don't change the whole culture of patient voice and patient engagement at all levels, we're probably not going to move very far at the direct care level as well. And we really need to be looking at what are factors influencing engagement. And so at the bottom, we need to help patients believe that this is part of their role. We need to pay attention to health literacy, although these interventions can actually improve health literacy as well. At the organizational level, we need to look at our policies and practices and our culture and whether or not we actually value the patient's voice and how do we support that. And then we also look at social norms, regulations, and policy. So I was in Japan in March, and in Japan, they don't even have to tell patients that they have a diagnosis of cancer. And it's part of their social norms in the country that it's okay. The family can know, but you don't have to tell the patient. And so I think in Canada, we're not at that stage, but we need to also pay attention to cultural issues of our patients, not just applying our own views. So finally, to put patients first, we need to really look at creating health policies that support patients first. And so already there's a key document around what's patient-centered care. All those key words are in my presentation and come out really strongly. If we're doing these things, we're really involving patients, putting patients first. We need to ensure leadership support, that moving anything forward isn't going to happen without their support. We need a patient-first culture that values patients. We need to provide training. This came out in the review that France did. On our website, which I'll show next, we have training, but France in Quebec City also has a number of training programs. She has the international inventory on training. We need to develop or gather tools to support patients first, and this came out also in the BC document. we need to measure patient-first outcomes. And so there is some work being done around how do we measure and incorporate this into direct care. And we need to look at how do we establish research priorities with and for patients. So I'll end on our website in Ottawa. For the Patient Decision Aid website, we have a number of different resources on the website, but we have all of the patient decision aids. We have decision coaching section with videos, frameworks, how to develop decision aids, and then all of the outcome measures are there in all the languages, and then also the implementation toolkit on how to move these into practice. So I'm going to stop now and open it up for questions and comments.
Yeah, just to say thanks, Dawn, and we'll open it up for sure. Carolyn. Right here. Got a roving mic.
I'm coming. Yep. I'm coming.
Thank
you. So,
Try this one.
yes. Hello. Yes. Thank you so much for your presentation. You spoke really powerfully about that final right-hand column of shared leadership and engaging patients for more powerful roles. And I wonder, I guess there are several aspects of that. You talk about providing training, and we ask patients as leaders to somehow speak on behalf of all patients when they're collaborators on research projects, all patients similarly situated or with something representative. It's very difficult for an individual to be representative of anyone but themselves. So I wonder how much tick boxing that encourages. It puts an unfair burden on patients, and there's no accountability loop. You know, we don't go back and validate what the patient is representing. So my step towards creating something a bit more powerful is a question to you, is how do we equip patients to have skill levels and to rebalance power differentials, to contribute on research teams or improvement teams with an equal strength? We don't have PhD programs for those patients, and yet we expect PhD level contributions.
But I think it's about a cultural shift that needs to occur that values all voices at the table. And there has been a shift right now from a research-only driven, research-only groups to even including nurses from the front line on their teams and managers from the front line on the teams and policymakers as part of the research teams. And so there is a shift going on in research to have more perspectives on the teams and patients as well. And so I think part of it comes with experience, but also some of the work that we did, there needs to be clear expectations around everybody. And when I work with my doctoral students, I actually have them doing touch in with the patients before meeting to prepare them, touch in after to see if they felt like they were heard, but also to make sure that they're comfortable in terms of their contributions on the team. And so I think it does take a bit more energy, but I think that it can be done, and it can be done well. And we just need people to get used to doing it, but also trained.
So we know that patients are providing. We know that patients are providing the energy and the time, and I wonder what we do in capacity development and leadership development if they are to take those equal roles. And I think that that's a gap. We have formal education streams and we have work environment streams for the other members of the team, but what about the patients who are doing it out of their own free time?
Well, and I think one of the big barriers in Canada is we don't have funding either. And so I went to the research institute that I'm a senior scientist, and I said, okay, how does funding work here? What's our policy for paying patients to be part of our team? And they said, oh, you have to go talk to ethics. And I said, no, they're not a participant on my study where I have to follow ethics. They're actually working as part of my team, and I want to be able to pay them for their contributions, or at least some payment. And there wasn't a policy. So I think SPORE is trying to develop a policy statement around this for Canada so that we get some guidance around even funding to support patients to be part of our team. Comment?
Yes, thank you very much for your presentation. I thoroughly enjoyed it. I have a couple of questions. One of them is we need to be teaching this to baccalaureate nursing students at that level. We also need to teach this to social workers and all the rest of the healthcare professionals, because if we don't do that, we're not doing service to the patients. And I think if we're going to teach it to the students, we need to incorporate that and ensure that it is occurring. And unless you examine something, currently students are not interested to know about anything unless it's being examined in this exam or that exam. So have you got any ideas about that? And the other thing that I wanted to say is that I teach a healthcare issues course, and in that I found out that the model that you're describing is in fact one of the US universities in Kansas has got community toolbox. I don't know if you're familiar with that. And they talk about all the stakeholders and what are if they're affected by something or they can affect something. And I think there are models that we can use, right, to teach the course.
Or courses. So on the website here, we have a tutorial called the Ottawa Decision Support Tutorial that we actually have our undergraduate students do at the school at the University of Ottawa. We also use it in research studies where we're implementing shared decision making as part of processes of care. And on this, at the end, if you score greater than 80%, you get a certificate of completion. And the final test is only 10 questions. And in each of the modules, it actually asks you questions and gives you the right answer as you go through. And so we just published a paper on this looking at over 6,000 users that have gone through using the online tutorial. And so and also we evaluated all their feedback, and it was all over 90% would recommend it. Like we had good positive feedback. So that's one resource that can be used. So the way it's used is that students are directed to use it, and then it's integrated into the exam as part of the course where it's done. Because you're right, if they go off and they use it, they don't necessarily, well, first of all, they don't have to go use it, and then if we're not testing on it, then they're probably not going to have learned from it. But and I also did do work at the University of Ottawa integrating this throughout the curriculum, and then as soon as I was done and published the paper, we changed our curriculum. We went to a 2+2 where all the sciences were in 2 years and all the nursing is in the last 2 years, and so the integration didn't work to maintain our integration, and so I think we need to look at opportunities to have this in curriculum. I agree.
The other comment I have is what kind of teaching are we doing for the patients or to the family? Because if we don't do that, then they're not empowered to be asking questions and holding us accountable.
Yeah. So the Ask 3 questions, the next paper that I didn't talk about is they actually found that people of lower socioeconomic status didn't feel comfortable asking any of the questions. And so the student's name as part of her PhD is Muscat, Danielle Muscat. For her PhD, she actually looked at building a training program to help them understand their role and prepare them and practice using the questions. And so they have more papers coming out around looking at how do you work with the patients and preparing them for being part of that role. So I know that's one example. I haven't done training directly with patients. I think I like the decision coaching role where we as all nurses can be easily facilitating this as part of our role as the educator, that we can actually be helping patients participate as part of the decision.
Thank you, Dawn. Sandra Loke from St. Paul's and UBC. I'm intrigued by your idea as a nurse, as a mediator, and how in your research you found that patients are asking us to step up to that role. And I'm just wondering what your comments or maybe some ideas about how we can help activate that. Because as I was listening to you, what came to my mind is that schism that exists between what we are doing with patients, or maybe to patients in terms of education, the introduction of shared decision-making in clinical practice, and then the big gap to the signing of the consent, where the nurse is not part of that triangle. And I see that as a space where if we could work in that space and help maybe close that loop, we might be able to do some of the work that you're inspiring us to do, and wondering what your comments are about that.
So I just wrote up one of our papers, it's just in press, on evaluating the nurse's role in prostate cancer and helping support men, because she's a neutral party. The men go to the different, the surgeon and then the radiation oncologist, and they're kind of confused because they're told you should do this. And so I evaluated the program in Saskatchewan and in Ottawa. And in both programs, similarly, but I'll talk about Saskatchewan, the way it works is the actually nurse delivers the diagnosis to the patient and then talks to them immediately around introducing what their options are and gives them the decision aid, books them to be seen by the nurse, where she actually then goes through and helps them understand their options. And then they go off to see the different physicians to talk about the options. So they're part of the decision coaching role is helping like right up front in that model. In Ottawa, it's a little bit different model in terms of how, but what they've done is embedded it into the pathway, the surgical pathway in Saskatchewan. And so Saskatchewan, when they integrated shared decision making, they started it in their surgical pathways and looked at the role of decision aids and decision coaching and joint replacement in prostate cancer, and there's a gynae condition, and also in spinal surgery, to really look at how do we help the patients learn their options and think through the whole process of decision making. And so it's not being done anywhere well, but there is opportunity for us to be thinking about how do we expand the nurse's role from being more passive delivery of information to really supporting in the process of decision making.
Hi there. My name is Netta. I'm a grad student at UBC, and my background is in emergency trauma medicine. And in an era of hallway nursing, and where we're constantly pushed to offload patients from paramedics and send paramedics back to the community, and doctors have time frames in which they have to see patients and come up with differential diagnoses and give, are they going to get admitted, are they going to get discharged home, etc. This is probably like one of the most important places that patients should be included in the decision-making process, especially when they're making life or death decisions for themselves or for their family members. And I'm just curious if you've experienced this, whether in discussion with your focus groups, with patients and or physicians and other allied healthcare professionals in departments such as emergency departments, using these tools, and how that can be brought into the culture of those fast-paced departments.
Yeah. So I have been doing this work for 20 years, actually. I started my master's in '98 and with Annette O'Connor. And back then we used to say, oh, we wouldn't do this in emergency because it's too fast-paced and there's no time. But in fact, what we found over the years is it's even more important, as you described, in emergency. And there is, in the Cochrane review, there is a paper on someone showing up in emergency with chest pain, and then whether or not, what level of intervention to do. It's a study done in the US. But I'll go back to my grandmother when she was 88 and she had a bowel obstruction, and I knew she had a bowel obstruction, and she got brought into hospital, and we were there all day. We went in at noon, and I think at about 9 o'clock at night they tell me she has a bowel obstruction. So anyway, and then they say, what do you want to do? Do you want her to go to surgery, emergency surgery, or do you want her palliative? And I'm like the granddaughter, right? And she's my favorite grandma. And I just wanted to cry. And my parents usually do her care. So I phoned my parents in Saskatchewan from Ottawa because they were on vacation. And I said, what should we do? And my mom says, ask your grandmother. But I was overwhelmed in the emotion of, oh my God, I don't want her to die. So anyway, I get off the phone with my mom, and I went into my decision coaching mode. And the resident comes and says, have you decided? And I'm like, I think you better tell my grandma what her options are. Like, what does it mean to be palliative? What does it mean to go for emergency surgery? What's the chance of her making it through surgery tonight if she has emergency surgery? She's 88, congestive heart failure, with his bowel obstruction. Like, is she going to make it? And so anyway, I coached the resident through helping my grandma learn about her two options. And my grandma was like, I want surgery. And they were pressuring us because they said, oh, like, she'll be next going to OR. You need to let us know right away because we need to save that spot for her. So I'm feeling the pressure. And my grandma decided. And then I worried all through the surgery, but she made it through. But she ended up dying a couple weeks later in that it didn't progress to being completely resolved. But at that moment, and I think it was the right decision because family were able to come and say goodbye. Like it worked out very well, but my grandma made the decision herself, and she was of sound mind at 88. So I honestly think that this can be done anywhere. The one place, though, I don't think it can be done, because I teach a course in this, a graduate course. One of the nurses said, I work in the operating room, and the patients show up for OR and have no clue what they've consented to. And they don't even, and they aren't even sure they want that surgery. And she said, if I stopped things at that moment, I would be in so much trouble because we have only this OR spot and we need to fill it and there's people on the waiting list. And it's not the right time at that point for us to be questioning what's been done. This poor patient should have had this support a long time ago in that process. So if I had my way, I would stop the surgery and not allow it to go forward without this discussion. But I think we need to be looking at how do we help before we get to the operating room.
Hi, Dr. Stacey. Thanks for your presentation. I was wondering if you could comment on the decision coaching role. I can see that it's a wonderful fit with nursing. But I know that I believe Jeff Belcora did a study on post-baccalaureate students trained as decision coaches. And I don't know what your thoughts are on that, or even lay people.
Yeah, so it
trained.
wasn't completely the model of decision coaching that we use in Ottawa, because I was involved in one of Jeff's research projects, the telephone base for women with cancer, with breast cancer. But what he does in his training is he takes medical students and he pairs them with the patient ahead of time to give them the information. He does use decision aids. And then that medical student goes into the consultation when that patient sees the surgeon or the oncologist. And that student has to do notes, and he has Scopus notes. And it's a process. He talks to the patient ahead, then they have to do notes following the consultation, and then they follow up with the patient. And so they're sort of like the transcriptionist for the patient. They're not the expert. They're in a neutral role, so consistent with decision coaching, but it's more around sort of following the patients through. And he brings in medical students for months at a time to do this repeatedly to help them develop their skills in communication, supporting patients in decision making.
Hi. So I'm a nurse at the Healthy Mind Center at BC Children's. And I was in school for a million gajillion years, so I always had access to peer-reviewed articles. And to my great dismay, this past year when I went to look up things, if I wanted to look up, what is the evidence on this, so I can talk to my manager, because I'm one of those annoying people that's excuse me, this isn't evidence-based. But even as educators for the patients, letting them know their options, we need to know their options. And I work at the BC Children's Hospital, and I went to log on, on a computer, and I'm like, oh my God, we don't have access to peer-reviewed journals. I'm like, we must have it in the resource center, at least on the 2 computers. I go up, we don't have access. I go talk to the nurse educators. I'm like, well, how are we going to get access? This is insane. We're doing frontline care. I'm like, you guys must have access. Our nurse educators at the BC Children's Hospital don't have access to UBC's library.
Yeah.
What are we supposed to do in terms of being able to advocate appropriately if we don't even have, as alumni, but for people that aren't. And the doctors, this is the other crazy part, there's a disparity because the doctors are usually associated to that, and then the nurses aren't. And then you have to pay hundreds of dollars to be a part of that.
So that's also part of why we create patient decision aids, because it actually synthesizes the evidence, formats it in a process of decision making that actually helps both clinicians and patients know what is the chances of things occurring and how well do these different options work. And so I know Sarah's actually in the audience. She's created one around vaginal birth after cesarean that's going to be looked at being implemented in British Columbia to help women that have had a cesarean understand their options after a cesarean. So that's one example. The HealthWise knowledge base actually has over 180 patient decision aids. And they're available in the province, but they've never been implemented. And so that is another resource that can be used as well. And so I think it's frustrating that I think at all hospitals, all academic institutions should have access to journal articles. But one of the problems is it depends on what article you pull and whether or not you're pulling, because there's lots of articles might say this and another one might say that. So I think the other piece is there's so much literature now being published that we can't keep up with the studies either. Yeah. So come to our website. You can link to under decision coaching, you can actually link to all the papers as well. And you can link to the PubMed article. And I try and publish open access because I am publicly funded. So a fair amount of my work is published open access. But at least you can see the abstract, and maybe you can have a colleague at the university send you or email me. I can send individual copies of the papers. I get asked all the time. But then you can at least have a look at the abstract.
Thank you, Dr. Stacey, for your wonderful presentation. So I'm an oncology nurse and I work at an outpatient clinic. I do have two questions. So going back to working in fast-paced environments, it's challenging to incorporate this practice as well as teach patients. So what would be the takeaway message? Maybe part of the answer was to just teach them how to do those 3 questions, but if you can speak more on to just like, I have 5 minutes with the patient, how can I incorporate this model? And my second question is if we do identify healthcare providers who are not providing patient decision aids or like shared decision making, not to the level that, that might be appreciated, how can we address this to them without offending them?
So I usually ask 3 questions a lot in terms of like a more active way of trying to figure out what alternative options are. But the Ottawa Personal Decision Guide is an excellent tool that it's 2 pages long, copied front and back, and it actually is a format for helping format the thinking around what are the options and what's important to you. And the piece that we miss is that piece around what's important around the benefits and the harms of the different options. And so I actually pull that out all the time. Well, I had a graduate student that wasn't sure about whether or not she wanted to continue her PhD. I said, well, go to the Ottawa Personal Decision Guide. But she also had done work on it in the past, so she knew about it. Actually, I've done it with 2 students. One was recently, and I said, you need to talk to your husband about this, because there was issues around whether or not she was going to get enough support at home to be able to come back into the program. And like, it's helpful for social decisions, and it's helpful for, my husband and I used it we just moved and we were buying our new place, and I wasn't sure we're on the right level of decision making together and what we liked, and I actually brought it out and we did it. I did the version for 2, and it was interesting hearing how the different things he valued, because things that he valued weren't necessarily the things I value, but in the end, we both were valuing, all of them matched to one of our 2 main options that we're weighing, like 2 different options we're considering. So I know it works, and I've been teaching the graduate course for many, many years. I've seen it in a number of clinical situations for a lot of different things. And so it's a way of helping format that thinking around the decision. So I'd encourage you to try that. Sarah?
Thanks, Dawn. Sarah Monroe, postdoctoral fellow at UBC. One thing came to mind for me when you were talking about sitting at your grandma's bedside and those 2 clinicians were doing the handover and didn't really want to engage. It's come up for us in that situation where implementing the next birth after cesarean decision aid, clinicians don't necessarily want to answer the questions when they come up. So if they're prompted to discuss, what matters most to a patient or to her family about their decision, they actually don't want to sit back and deal with the responses about the options moving forward. So I wonder if you have any suggestions around implementing when clinicians don't want to go take the next step and provide an answer. And they're actually trained not to ask a question, because if they don't know the answer to it, they shouldn't be asking it in the first place.
So one of my doctoral students, Laura Boland, she did work around talking to people that had already been trained and why they weren't using shared decision making. It's at the Children's Hospital in Ottawa. And then we also did some work in this area. And one of the things that she found when she interviewed around 80 people trained, and then in that period after, is that when it was most successfully implemented is when the team came for training, as opposed to just the individuals. And most of the time it was just individuals that came for the training when it was offered, but it's around that culture and the environment. Like, we need to shift in obstetrics, that whole team values that this decision or decisions and women's voices should be heard in all decisions. And so it's around shifting the team and because we're going to, in my prostate work, the patient said to me, when I went to see the radiation oncologist, he said, my job isn't to help you make this decision. My job is to tell you about radiation. And he was upset that we're helping patients be involved in decision making and telling patients to talk to their doctors about it. And so we haven't shifted over across all clinical areas. We have a long way to go, I think. There's a question at the back.
Oh, yeah. Hi. Sorry, I wanted to give a quick response about accessing research here in British Columbia. My name's Catherine Miller, and I'm a librarian from UBC, and I work with nurses. And I wanted to invite anybody who's having difficulty getting access to literature to speak with me. We do have access through EHL BC to content, and so through the Learning Center, you should be able to get in and get access to the content you need. But I do want to invite, if you're ever having difficulty, just to connect with us through UBC Library, and we will work with you to get what you need.
That's fantastic news.
One more. Sorry.
Hi, sorry, thanks. The question is actually more for the UBC organizers of the event. So I've heard several comments about how do we help upskill patients and public to help inform themselves in terms of healthcare. And I noticed that, and anyways, this is just my observation, that perhaps for this particular lecture in what we're talking about today, that we haven't invited maybe people from the Patient Voices Network of BC or like the Keen membership in VCH, and I'm just wondering what the thoughts are about that.
Oh, the big armor's coming out.
So we advertise far and wide and go through the usual channels around social media, and there are some targeted invites that go out. And I think this afternoon with the Petacucha we had nice representation from people with patient experiences. So I think we've tried really hard to have a representation around that. We certainly do, reach out to specific groups who might have a key interest. Yeah.
I think I'm handing it back.
Okay. Being no other questions and being right on the time of 8:30, I do want to thank folks for coming out tonight. It's been great to host this 50th. Dawn, amazing job. Such a rich content to think about. Lots of questions and thoughts going forward, and Dawn is with us tomorrow. Might have a little bit of time and certainly is around for a little bit longer this evening. I want to thank you for your participation and for the questions. Also want to give a shout out to Marilee Hughes, who does the heavy lifting on these events every year. Does a terrific job. We had terrific support from her and such a great event, and also the STARS committee who help us design the program each year. Again, thanks for coming. Thank you to you, Dawn, and look forward to seeing you in our centenary year for the 51st Marion Woodward lecture. Thank you.